Thank you for the invite. I believe the tone for this will be a bit different from the prior lectures. I will try to stick to the time. I know we're a little bit behind. So basically what I will be discussing is different. I'm not going to discuss about lymphomas, upfront therapies, relapse therapy, CAR T cell therapy. That has been covered already. What I'll discuss basically an issue that usually faces family medicines more than lymphoma specialists or hematologists. But still, as a hematologist, we are sort of the last resort that patients or even physicians go to evaluate a case with the lymphadenopathy. So the problem with this is basically lymphadenopathy is a common referral to hematology. Usually in a primary care setting, the incidence of malignancy is quite low. But however, in tertiary referrals, malignancy can go up to as high as 40 or 50%. So really distinguishing the self-limiting causes versus a life-threatening mimics is very essential, and discovering which is lymphoma or which is not. Not infrequently, I'm covering consultation service and they consult me for a patient. We have someone with lymphadenopathy, we took a biopsies, it's not diagnostic, please come and evaluate. Make sure that we're not missing on something big, and this is what I'm trying here to discuss. So let's start with the definition. When it comes to lymphoma, there is a size criteria, more than 1 centimeter in general, considered to be lymph node enlargement. A rubbery stiff fixation to subcutaneous tissue is an issue, as well as the time frame. Lymphoma that appears for a couple of days and go back, this is probably inflammatory. If it persists more than 2 weeks, is warrant evaluations. More than 4 weeks is sort of a red line or a red flag. So this is the mnemonics for the differential diagnosis of lymphadenopathies in general. Not all lymphadenopathy is caused by lymphoma. There are other things that can cause it. One is cancer, metastatic, whether it's a solid tumor or hematology, hypersensitivity infections, connective tissues, granulomatous disease, atypicals, and others. I'll try to focus here on this talk on rare causes, since I'm talking to an expert here. Red flags, as you all know, if you're dealing with an elderly individual, if the lymph node enlargement persisted more than a month, if this is a supraclavicular lesion, B symptoms, abscess of infectious etiologies, all of these are red flags that you probably need to pay a closer attention to that patient. When it comes to the benign versus malignant, underlying biopsies, doing a biopsy for someone with lymphoma probably will get you 50% of time malignancy if this lymph node persisted more than 4 weeks. The location matters. If this is a supraclavicular lymph node that persisted for a very long time, the risk of malignancy is super high. Inguinal lymph node, because it's draining the genital area and the perianal area, it's sort of reactive. And this is typically as well what we see in patients with, let's say, widespread lymph node enlargement. We typically go for a cervical rather than inguinal, because inguinal you can sometimes be difficult to interpret. Epitrochlear is always pathological, and there is a specific clinical scenario which I will show in a second. So let's start with Castleman disease. Castleman disease is a disease that can present again with a lymph node enlargement. This is sort of not a single disease. This is a spectrum of interleukin-6 collective disease. Can be classified into either unicentric or idiopathic multicentric, which is the human herpes virus 8 negative, and there is the human herpes virus 8 positive multicentric Castleman disease. The unicentric usually present with a single lymph node enlargement, typically in the young individuals, and usually doesn't cause symptoms. Symptoms can be arise because it's compressing on a vital organ, or it's just looking, this is sort of a disfiguring lymph node enlargement. Doing labs usually normal, and systemic inflammation is very, very, very rare in this situation. What do we see in pathology? We see the key feature is regressing germinal centers. As you can see here, the first picture, the lollipop lesions, which is basically just vessels infiltrating and penetrating the germinal centers. And the onion skin, as you can see here, I don't know if you can see it here, the onion skin is basically expanding marginal zone surrounding the germinal center. This is sort of a classical finding of Castleman disease. So what do we do with solitary unicentric? Basically just excision. Simple excision is curative. If you can't do excision, if the patient is asymptomatic, just leave him alone, don't do anything. There is really no need to do anything in that situations. If it's causing symptoms, then either cilatoximab or tocilizumab can be used. But again, this is very, very, very rare in someone with a unicentric Castleman disease. Let's go with the multicentric. Multicentric, usually an involvement of 2 or more lymph nodes associated with systemic inflammatory response. And basically, what is driving all of this is a high interleukin 6. So this is usually divided based on the etiologies. If you know the etiologies, which is human herpes virus 8 positive, then you're dealing with a human herpes 8 positive Castleman disease. Otherwise, it's either negative, and negative can be subdivided into either poems or tafro or others idiopathic, which we will discuss in a second. Let's start with the human herpes virus 8 positive multicentric Castleman disease. Basically, what happens is because of a low immunity in someone with HIV infection or someone older, the immune system cannot get rid of human herpes virus 8. When it cannot get rid of the human herpes virus 8, it gets integrated into the host DNA, and it does produce viral interleukin 6. When it produces viral interleukin 6, it basically just produces the storm that you would expect: cytopenias, fever, B symptoms, weight loss, etc. Patients population, majority are either HIV positive or immunosuppressed individuals. It can come in an immunocompetent individual, but it's quite rare. And there is a risk to having either Kaposi sarcoma or lymphoma on those individuals. What do we see when we do the staining for a latent nuclear antigen for human herpes virus 8 latent nuclear antigen? You can see it here, positive. This is sort of the gold standard pathognomonic. Whenever you see it, you know that you're dealing with a human herpes virus 8 positive multicentric Castleman disease, or a plasmacytic morphologies, as well as you can see here. So what's the treatment? The treatment is rituximab. Rituximab gets rid of the reservoir cells, gets rid of the B lymphocytes. By doing this, basically majority of patients get cured. Steroid usually doesn't help a lot. It can temporalize the behaviors. Patients with symptoms can have an improvement, a little bit of improvement with steroid, but usually as soon as you start tapering steroid, the symptoms come back again. Of course, if the patient is HIV positive, then antiretroviral therapy is essential in the treatment of those individuals. Please keep in mind that interleukin 6 in this setting, it doesn't work. Cilatoximab, which is a monoclonal antibody against interleukin 6, doesn't work here because cilatoximab is directed against human interleukin 6. Here, we're dealing with a viral interleukin 6, so it doesn't work. Tocilizumab, which is a receptor blocker, still binds to the glycoprotein 80 subunit of the receptors, whereas the viral bind to 130 subunits. So usually interleukin 6 inhibitor doesn't work. Ganciclovir, there are some emerging reports that it may work, but still it's sort of not standard and sort of a last resort. Cidofovir doesn't work here. It's important to rule out the presence of a coexisting Kaposi sarcoma. These are, again, this malignancy is associated as well with the human herpes virus 8 positive, and it's present usually in around 13% of patients with Castleman disease. Let's go with idiopathic multicentric Castleman disease. This is the definition. Idiopathic is basically when you rule out the presence of human herpes virus 8, you rule out the presence of Bowen syndromes, and you rule out the presence of autoimmune cause. So basically, this is a diagnosis of exclusion. So this is the criteria. For the sake of time, I'm not going to go through each one of them, but there is a major and minor criteria, and there are subtypes, TAFRO subtypes, or idiopathic NOS subtypes. Let's go with the TAFRO syndrome, which is basically the thrombocytopenia and a Sarca fever, reticulin fibrosis. You see it in the bone marrow when you do the bone marrow biopsies, and organomegaly. This is sort of a simple differentiation between the idiopathic and TAFRO. Platelet count usually in TAFRO symptoms is quite low, but the immunoglobulin is normal, and the morphology is sort of a hyperplastic atrophic. So what's the pathogenesis here? Again, it's an immune dysregulation, upregulation of mTOR pathways, as well as which drives basically interleukin 6 in the body. The treatment here is anti-interleukin 6 therapies with either celotoximab, which is the only approved therapy that can be used in idiopathic multicentric Castleman disease. Tocilizumab can be used if you don't have access to celotoximab, and the response rate is around 34 to 50%. Please make sure that we need to rule out the presence of POEM syndrome in those patients, because if the patient has POEM syndrome and you can radiate, radiation is probably going to cure the patient. You need to rule out the coexistence lymphoma. I had a patient of mine presented with a typical human herpes virus 8 negative, cytopenias, B symptoms, started him on tocilizumab, went into remission. He was happy, count recovered for 2 years, and then the symptoms came back again. Interleukin 6 was shooting up. And when do the PET scan and biopsy, turned out to already progressed to a lymphoma. So this is something that we really need to keep in mind. So what do we do in non-responder? Steroid can help, but steroid, again, is a temporary therapies. mTOR sirolimus can be used as well. There is an emerging data on sirolimus. And shop-like therapy is sort of a last resort. When tocilizumab or celotoximab doesn't work, you can use them. Unfortunately, the response is short-lived and the disease tend to come back again afterward. Another mimicker for lymphomas is an IgG4 related disease. This is an immunomediated pro-inflammatory, pro-fibrosis disease that can affect any organ. Traditionally, it affects the pancreas, so it can mimic pancreatic cancer. It can affect the biliary tract, mimic cholangiocarcinoma, and of course, generalized lymph nodes, lymphomas. So this is a disease of a sort of an older individual in the 5th and 6th decade of life. Again, as I mentioned, the sites of involvement can be pancreas, salivary, orbit, retroperitoneal, classically causing fibrosis. So in someone presented with a retroperitoneal fibrosis of unknown etiologies, IgG4 need to be excluded, because this disease tends to be very highly responsive to steroid. So the distribution can be generalized or localized. For lymphadenopathies, it's usually non-tender and can mimic low-grade lymphomas or Castleman disease for that matter. What do we see in histology? This is the picture of the histology that you see in IgG4 related disease. Is basically a dense infiltration by lymphocytes and associated fibrosis. So the diagnosis relies on an increase in IgG4 plasma cells. We look more to the ratio rather than the absolute increase. So IgG4 higher than IgG cells more than 40%, and absolute count in the biopsy, within the biopsy more than 100. This is a mimicker for lymphomas. However, lymphomas, as you all know, is usually a monoclonal disease. So you will see light chain restriction, whereas an IgG4 related disease is basically sort of a polyclonal. So you wouldn't see light chain restriction. It's very important to check kappa and lambda to rule out before labeling a patient IgG4 disease. It's very need to rule out the presence of a coexisting or a lymphoma for that matter. We really need to make sure that we don't rely on serum immunoglobulin 4, because it tends to be normal, it can be normal in around 30% of patients. So we rely on IgG4 within the biopsy to diagnose the disease. And the treatment is simple: steroid, very highly responsive to steroid. Once you start steroid, the mass just shrink, and then you start taking off the steroid. It does tend to come back again with if the disease came back again, you can use rituximab. I had a patient of mine with an orbital IgG4 steroid. She was put on steroid for a very long time, developed cushingoid, diabetes, etc. With rituximab, she went into CR, and now she has been 2 years in CR. It's very important to rule out, because it's a mimicker of malignancies. We really need to rule out carcinomas or lymphomas for that matter. This is a common thing that we as a lymphoma doctors receive all the time. We receive a call from pathology or a call from other colleagues from other centers saying that I have a patient, young individual with an enlargement in cervical lymph node. They took a biopsy and they told me this is a progressive transformation of germinal center. What does that mean? This is a benign condition. This is not a pre-malignant condition. However, the thing that we need to keep in mind that this can coexist with the nodular lymphocyte predominant Hodgkin lymphoma. So important to look at the PET scan, making sure that the biopsy was done from the highest SUV uptake, etc. But once you're sure that this is the case, then it's usually something benign, nothing really to do from a hematology standpoint. Another thing is florid follicular hyperplasia, which can happen usually in association with an autoimmune disease, rheumatoid arthritis, SLE, and HIV patients. Again, autoimmune disease is a predisposing patients to the presence of lymphomas. So once the biopsy is taken, and this is what it showed, follicular hyperplasia is basically hyperplasia, don't do anything. Infectious mononucleosis is a great mimicker for Hodgkin lymphoma because of the presence of what it looks like Reed Sternberg cells. But usually in infectious mononucleosis, the immunoblast is usually polyclonal. In a setting of lymphomas, as you all know, it's usually monoclonal. And the infiltrating mononucleosis is usually CD8 positive, whereas, as you all know, in Hodgkin lymphoma, is CD4 positive. Another important thing that we need to keep in mind, although this is considered part of lymphomas, but this is an indolent lymphomas, EBV mucocutaneous ulcer, as you can see here in the picture. Usually it's present in the oral cavity and the GI tract. Biopsy proven EBV positive lymphomas happens usually in immunosuppressed or elderly individual. And the simple treatment for that is just withdrawing the immunosuppression is good enough. Usually majority of those patients go into CR. The thing with that is usually it doesn't really deserve much of a treatment, doesn't deserve R-sharp therapies or extensive therapies, and the prognosis is excellent. Kokochi disease used to be described in Asian, but now it's been reported in many different countries as well. This usually patients present with a cervical lymph node, fever, leukopenia, and when you do the biopsy, it showed necrotizing lymphadenitis. However, the key feature in this disease is the absence of neutrophils. So what you see necrosis, but you don't see any neutrophils within the biopsy. This is very characteristic of Kikuchi disease. There is the diagnosis relies on biopsies. However, there is in a pediatric setting, I believe a Japanese trial looked into. They sort of gave a proposal for a criteria based on the lymph nodes, size, the temperature, and beta-2 microglobin, and they claim that it has 100% sensitivity and specificity. However, because the disease is rare, still doing a biopsy is very essential, and the diagnosis is self-limiting. If you leave the patients alone, usually the disease will resolve within a month or up to 3 months. However, if the patient has high symptoms, giving steroid can speed up the recovery. Rosai-Dorfman disease, this is a non-Langerhans cell histocytosis, again presented with a sinus histocytosis and massive lymphadenopathies. Can present with usually in the neck area, painless cervical lymphadenopathies, and it has the characteristic of histocyte engulfing intact lymphocyte, and this differentiates Rosai-Dorfman from other histocytic disorders, and of course it's an S100 positive. Syphilis as well, I'm just speeding up because of the time. Syphilis is a great imitator as well for lymphomas. It can be in the inguinal and cervical. It has been named in the literature as the great imitator. And it's very important for someone with a lymphadenopathy, which we don't know the cause, to send for a syphilis, because if this is missed, it's very hard to reach the diagnosis. In the past, this is for sort of a historical interest, and this is why I mentioned at the beginning of the lecture the epitrochial lymph node. In the past, they used to have the sailor handshake, in which they will shake the whoever is going to board the ship, they will shake their hand, and then they will check the epitrochial lymph node. If it's enlarged, they would know this guy has syphilis, you will not board on this ship. This is sort of a historical interest, but someone with epitrochial lymph node, syphilis is one of the causes. Certainly not a diagnostic by any means. HIV-associated lymphadenopathy, HIV predisposes patients to lymphomas. HIV patients, they do get infections, fungal, TBs, etc. And HIV itself can present with a lymphadenopathy. Very important to exclude human herpes virus 8 and TBs and other infections. Drugs can cause lymphadenopathies. The most famous of this is phenytoin. However, believe it or not, allopurinol, which we commonly use for tumor lysis syndrome, can as well cause a lymphadenopathy. Very rare, but it has been described in the literature. Phenytoin has been induced pseudolymphomas, can occur months after initiation, so the patient can be on phenytoin for a very long time and all of a sudden they develop with lymphadenopathies. And when you do the biopsies, you see paracortical expansion with a lot of eosinophilia, which give you a hint that this is probably drug-related changes. And switching the therapy from phenytoin to switching the therapy from phenytoin to something else usually lead to regression of this disease. Silicone lymphadenopathies. Silicone is used for cosmetic reasons. Females with breast implants or even for joint replacement, the silicone itself can go to axillary or supraclavicular lymph node, and when you do the biopsy, you see the presence of a multinucleated giant cell surrounding a reactive material, which is silicone. Last but not least, post-vaccination lymphadenopathy. I believe all of us have seen it with a mandatory vaccination for all patients. This usually happens with the COVID vaccines. After giving COVID vaccine, patients will present with an enlarging lymph nodes. You do a biopsy, it's a high PET uptake. So this has been described already in the literature, typically in the axillary or the supraclavicular lymph nodes, common with Moderna rather than Pfizer, and usually resolved by week 6 to week 12. And the management here, PET scan is not diagnostic here. PET scan can actually throw you off because it will show hyperactive metabolic uptake in the lymph node. However, if the history matches, you can observe the patients before going for a biopsy, especially if the patient does not have any other symptom that suggests lymphoma. These are my references, and thank you.
Thank you.